So good morning, ladies and gentlemen. My name is Jens Chapman. I welcome you to the new academic year and our grand rounds on a topic which seems to be so solved and so mundane. That's ankle fractures. And today we'll put you to the test in terms of your knowledge on ankle fractures and see what you really know. And to do this, we have one of our eminent chief residents, Dr. Greg Blaisdell, who's going to lead us through a number of case scenarios and questions and problems. And we'll all be put to the test with our little audience response system. So Greg, why don't you come up? And he will have two experts. We're very proud to introduce to you Dr. Bob Dunbar and Dr. Dave Barei, eminent traumatologists at Harborview, to basically guide us through their thought processes. But this is interactive. We have microphones, so please just introduce yourself if you have any questions. Greg, take it from here. Good morning.
Thanks, Dr. Chapman. Hello, everybody. So my name is Greg Blaisdell, and I'm going to be joined by Drs. Barei and Dunbar today, and we're going to talk about a few of the controversies in ankle fractures that seem pretty straightforward until you really dig into the literature and figure out why so much of this is still up in the air. So we're going to cover some relevant anatomy just to get things started, go through the typical radiographic workup, the classification of ankle fractures, some of the treatment specific recommendations from the literature, special considerations by injury, and these are going to be the more controversial topics that we deal with these days in ankle fractures, and then some of the host-related factors that are still puzzling us as to how to give some of these more complex patients the best treatment. So I'm going to start with a case, though, and this is a 68-year-old male who was on a motorcycle trip out of the state of Washington and tipped his bike over at low speed, was evaluated in an outside facility, and was found to have this ankle fracture, and was told he could be weight bearing as tolerated, was given a walking boot, returned home, and presented to our clinic full weight bearing with some ongoing pain, but about a week out from injury. And these are the weight bearing films from his initial presentation in our clinic. So you can see a mildly displaced lateral malleolus fracture. And my first question for the audience is, what's the next step in treatment for this gentleman? Should he be weight bearing? Should we do further testing, more advanced imaging, or just book him for surgery? So more ankle radiographs for most, and some people want to take him straight to surgery. So the next question, for those 66% of you that answered order a stress radiograph, what's the best way to do that? And it looks like the large majority of you want to do a gravity stress. So that's what we did, and you can see that he did have some displacement there.
What is a gravity stress? Can you explain that quickly?
I can, and I'll be going over it in detail later in the talk, but essentially it's a more patient-friendly way to get a mortise radiograph with gravity pushing the foot into external rotation and lateral displacement. And as you can see, it allows the foot to essentially push the talus out from underneath the mortise in a lateral direction. And we'll go over in detail the reasons to do one or the other in a few minutes here. So the next question is decision on management. Okay. And it looks like a lot of you want to stress the syndesmosis after you fix the lateral malleolus. Very good. So a little bit about an ankle anatomy. Essentially, the ankle is a hinge-type joint, but it's a little more complex because there are three bones that make up the joint, and the tibia and fibula are connected by a soft tissue structure, the syndesmosis, which I'll go over in a second. But it's a joint that requires a huge amount of force for the amount of area that's available for the joint. And a couple of structures that I pointed out that we'll be going over in detail today are the Chaput tubercle on the anterolateral tibia, as well as the Volkmann tubercle, which makes up a portion of the posterior malleolus that we'll see demonstrated in some injury films today. Looking at the medial side, the deltoid ligament is the soft tissue structure of interest, and on the bony images you can see the anterior and posterior colliculus of the medial malleolus, and the insertion of the superficial deltoid is on the anterior colliculus, and the deep deltoid is thought to insert along that posterior colliculus there. On the lateral side, the lateral collateral ligaments are made up by a group of ligaments that stabilize the distal fibula to both the calcaneus and the talus. And then the syndesmosis, which we're going to go over in detail today from a standpoint of how to diagnose and treat these injuries. It's relatively complex. It's made up of both anterior and posterior inferior tibiofibular ligaments, which play a huge role in keeping the fibula stabilized in its articulation at the distal tibia. The interosseous ligament is deep to those and is the check rein to the fibula staying with the tibia. So how do we radiograph the ankle when somebody comes in with an injury? There are three standard views, the AP, mortise, and lateral. On the AP, we have classically looked for a few different relationships, and these are described as a tibiofibular overlap, which should be somewhere in the order of 10 millimeters. If it's less than this, then that's concerning for a syndesmosis disruption. The clear space of the tibiofibular joint, which really that's your best view at the width of or at the articulation of the incisura of the fibula with the tibia, and then talar tilt is something you look for to determine if a lateral ankle injury has caused shortening and resultant talar tilt. The mortise radiograph, a couple of key findings we look for is the medial joint space. Does it look wider than the superlateral joint space? So the ankle should be relatively symmetric all the way around the mortise here, and we use the superior lateral articulation here and compare it to the medial space, the medial clear space. And those should be relatively close to one another in a normal ankle that's not degenerative. Dr. Weber in Switzerland described the dime sign back in the mid-'80s when he was describing how to reconstruct fibular malunions, but it's actually had an immense influence on how we determine whether or not the lateral malleolus is in fact displaced or not. And again, related to that is the Shenton's line, which if you look closely, there should be a normal articulation here at the distal tibia and fibula in the mortise that looks like it's essentially one continuous structure, and you can see it elevated on this figure up at the top here. Lateral radiograph, primarily we're looking for talar displacement in antero-posterior direction, signs of subluxation or dislocation. This is the view where you're going to have your best look at the posterior malleolus, although we'll show later that it's actually not necessarily always the best view. The lateral malleolus most typically has a spike that exits posterolaterally, and it's best viewed on this image as well. And you really want to make sure there are no other occult injuries in somebody presenting with ankle pain, such as a talar neck, base of fifth metatarsal fracture, anterior process of the calcaneus cuboid, and any joint subluxation. So other radiographs you want to consider when you're working up people with ankle pain and any signs of ankle injury. In general, in orthopedics, we try to image the joint above and joint below because we do get fooled, especially in these, especially in the extremities that have two long bones, such as the forearm and the leg here. You want to look at the entire length of each of those bones because you don't want to miss a Mason-Ove fracture of the proximal fibula like this when you don't identify any other fracture of the ankle, but some displacement. So we do have classification systems, multiple, which I'll review here quickly, but our goal in orthopedics is to decide who, in fact, has an unstable joint, an incongruous joint, or an impacted joint, and those are good reasons to consider operative management. Unfortunately, all the current classification systems we have, which have been around for some time and have not been replaced as to date, are relatively weak at giving us the best insight as to how to treat these. So the Lauge-Hansen, the Weber classification, the OTA classification I'll review. Lauge-Hansen did some experimental work in the 1940s in Denmark and found 4 main fracture types, and you see them listed here. He described these based on the foot position at the time of injury, either supination or pronation, and then the force applied to those is the second word in fracture type. So you can see supination adduction shown here with the supinated foot, the tension side of the injury is going to be laterally, and that tends to be the initial injury, which then allows the foot to adduct further and cause impaction of the joint and a more vertical shear type medial malleolus fracture. The supination external rotation, which is really the most common type of ankle fracture, and it's a fairly classic pattern, is denoted by an initial tear of the AITFL, and then this propagates into a fibula fracture, characteristically starting at the distal anterior fibula at the level of the syndesmosis and extending out posterolaterally, then propagating to a posterior malleolus fracture or disruption of the posterior soft tissues, and then finally the medial structures either result in a fracture or soft tissue injury. So those are in contrast to the pronation injuries, which you see the position of the foot at the beginning of the injury puts the medial-sided structures on tension. Those fail first, either with a deltoid rupture or medial malleolus tension type of avulsion type fracture, and these then propagate into fibular fractures, which tend to be in the abduction injuries, not always, but tend to be transsyndesmotic or suprasyndesmotic, and in the external rotation type injuries are classically the suprasyndesmotic injuries, which we also know of in the Weber classification as C types. And we'll go through Weber's description of ankle fractures, tried to simplify the system, 3 types, A, B, and C, and these are based on the injury at the level of the plafond above or below. And if you look at the simplicity of this fracture, it doesn't describe the medial-sided injury, so these are characteristically more reproducible in a discussion amongst surgeons. However, they leave a little bit to be desired when you're trying to make your best treatment decisions, because there's a little less information involved. However, it is a reproducible classification that is very familiar to the orthopedic world. So the OTA classification is built off of Weber's description of ankle injuries and has been complexified by an extreme amount to the point where there are now 27 different types of ankle injuries described. The trouble with this classification, as you all know, is that the more subtypes of any type of injury available in a classification, the less people like to try to describe those, because the reliability between observers of different injury patterns goes down significantly as you go up in numbers of different subtypes. There are issues with each of those classification systems. Our main goal is to treat these effectively and prevent instability of the joint. And a main issue, as we'll go through later, is none of these really describe the condition of the syndesmosis at the time of injury. So then, which fractures need surgical fixation? In the simplest terms, once the talus has become destabilized from its position in the mortise, whether by bony or soft tissue injury, the ankle is rendered unstable, and over time we found it extremely difficult to maintain stability with casting, splinting, or other external means. And this has been really the impulse behind operative fixation of these injuries. Yablon in the late 1970s showed us that the talus characteristically travels with the distal fibula in displacement pattern after these injuries occur, and restoration of this articulation is essential. The reason we go ahead and fix these is because there are pretty serious consequences to not doing so. This is a joint with small contact area, but huge loads going through the articulation, and Ramsey and Hamilton in a classic study from the 1970s showed the contact area of the tibio-talar articulation really suffers immensely even with just a millimeter of displacement. And these pictures show the carbon imprints of the contact force on the dome of the talus. And even at 1 millimeter, the contact area goes down incredibly. There have been further studies over time to support that, and they've added a little more in that fibular external rotation is a factor. Moody showed that plating the fibula actually restored the normal joint, and Thordarson showed a couple other findings of particular interest. It's just that lateral talar translation itself, aside from a medial injury, can cause a decreased contact area. external rotation of the fibula, which is very common in these injuries, and shortening all change the contact forces. So our obvious indication for operative management of ankle fractures is the bimalleolar fracture. It's unstable. A reduction to get the talus back under the tibial plafond is extremely hard to hold because a medial force on the hind foot can cause, there's no medial buttress in the medial malleolus to push up against, so these are inherently stable. And there are implant choices when we talk about how to fix these bimal fractures. Fixing the fibula, the classic debate has been the posterolateral anti-glide type plate, and specifically I'm talking about Weber B or supination external rotation ankle fractures, which have that posterior spike to create an anti-glide force with your posterolateral plate, as seen in this image here, as compared to a lateral plate with an interfragmentary screw, which has been shown to be a reliable construct in biomechanical studies from many years ago. The posterolateral anti-glide type plate is actually biomechanically superior, but even still today, both are reasonable applications for these injuries. A couple of more recent advances to fixation of lateral malleolus is popularization of the double plating, and this is a periarticular plate here, which is somewhat more stout than the standard 1/3 tubular plate, which has been classically applied, as shown in both of these images here, using K-wire fixation up the shaft of the fibula to create an environment for those screws to interdigitate into, and then the high fibula fracture, which is fixed and then stabilized at the level of the syndesmosis for rotational control. And then on the right is a locked plate design, as you can see. Medial malleolus implants, really the application of each one of these depends on the injury type, but the two on the left are both good treatments for the short oblique or transverse type of medial malfracture. The screw fixation has become more popular over time, even though both are of adequate strength to hold the fracture reduced, probably mostly because the tension band is more difficult to apply, and it's a little harder on the soft tissues. It's prominent, and people tend to be bugged by those. You can see that for increased fixation, we go with longer screws through the medial mal, and then buttress plating of the medial malleolus, more useful in the supination adduction type of injuries, the vertical shear component fractures of the medial mal, which we'll get into later. So now we're going to cover a few controversies that are ongoing out there in the world of ankle fracture treatment. And I'm going to start with the lateral malleolus fracture with a deltoid disruption. So just a lateral bony injury. This is the classic Weber B ankle injury. It's extremely common. Every orthopedic surgeon that takes general orthopedic call is going to see numerous injuries like this each year. The medial structures, when intact, meaning the medial soft tissues, the deltoid ligament, are unlikely to allow talar displacement. And all the way back to 1985, a 20-year follow-up study showed that if those structures are in fact intact, then the ankle will remain reduced, and patients do well long term. The difficulty here is that the consequences of missing a diagnosis of a medial soft tissue injury, the deep deltoid injury, can be pretty significant for a young patient who's otherwise active if they do have late displacement and widening of the mortise. So we've relied on physical exam findings over time, and we'll talk a little bit about why maybe we have to shift our thinking on that. The goal is to identify the ligament injuries, to use diagnostic tools that actually work, and to help our surgical planning that way, to prevent both over-treatment of patients that otherwise will heal with a stable ankle mortise, and to avoid missing patients who have an unstable joint that needs to be surgically managed. And we've looked at the medial clear space as an indicator for how to go ahead with treatment, and you can see these three injuries here, the yellow line being the medial clear space, and we've decided as a field that if it's an otherwise normal joint without degenerative changes, again, as mentioned earlier, this superior lateral tibio-talar clear space should be essentially symmetric to the medial clear space. And I bring that to our next question, which raises the question, which of these patients actually has medial-sided instability? It looks like patients 2 and 3 obviously have medial instability. That's good observational skills by the people in the room. Some of the people in the room think the first patient on the left also has medial instability, and we'll certainly be talking about that later in our case discussion. So, medial symptoms. A lot of people that present with an ankle injury and a lateral malleolus fracture do in fact have diffuse ankle pain. Over time, one of the indications for surgery on the lateral malleolus is medial pain and tenderness and ecchymosis. As one would infer, if the medial side of the joint hurts, then there is potentially an injury there, and that could warrant stabilization of the lateral side to keep the mortise congruous. So what we've relied on over time are symptoms, and now more recently the medial clear space as evidence for injury. The trouble is that the medial clear space is not always wide, even in these ankle injuries at presentation. So there's been considerable debate over time about how best to determine if they are becoming unstable or if they are at risk to become unstable with non-operative management. So Eagle back in 2004 looked at 101 patients that presented with an intact mortise, no displacement, but a lateral malleolus fracture, and they tried to study the medial symptoms as how they compared to the stress exam, which they use an external rotation stress test. In particular, they did have a stress-positive group without any medial signs of injury, and they had a patient discussion between the surgeon and the patient, and between the two of them made a decision about whether or not to go with operative or non-operative treatment. Strikingly, they found a 65% rate of medial clear space widening on ankle stress films. And this did not correlate with medial symptoms. So the classic thinking of medial-sided tenderness or ecchymosis is going to be related to your deltoid injury. In fact, showed that the stress-positive group, about half had medial symptoms and half didn't. And you could see the sensitivity and specificity of these patient symptoms are actually quite poor when you're trying to make an operative plan. So out of the 30 people that actually presented with medial symptoms and a positive stress test, again, the decision was given to the patient to go out with operative or non-operative treatment. And out of the 20 people that underwent non-operative treatment, they found reliable healing in the majority. But they did remark that two people, 2 out of 20, so 10%, did have widened mortise at their final follow-up of 7.4 months. And as you can imagine, if a young person has a widened mortise 7.4 months after an ankle injury but is 20 or 30 years old, there's a lot of time for that incongruous joint to be loaded abnormally. And we've already talked about the contact stresses involved there. So there's a 10% chance that you're going to miss you're going to discharge a patient from your clinic with a widened mortise and potentially have problems with degenerative changes. So they concluded that we can't rely on the medial symptoms alone. If the medial structures are in fact intact, they'll do well over time, but we be aware of the widened mortise. Another study, 2007, looked at, again, at 55 WebB patients with non-displaced mortise on presentation. These patients, again, had a mortise view and external rotation stress compared to the presence or absence of medial symptoms. And sure enough, a large majority did have widening of the medial clear space. Again, plenty of patients with medial symptoms had a negative stress film, and a similar number of patients with positive stress had no medial symptoms. So again, another study that shows we can't really rely on clinical symptoms on the medial side of the ankle to determine instability. And one more study showing a similar set of findings, making note of the fact that if we're relying on medial symptoms alone, we're going to get into trouble with reliable management plans. So something to stir things up, though, is a paper recently published in JOT, a small group of patients who actually did have positive widening, but on an MRI evaluation, they were found to only had 19 out of the 21 only had a partial rupture of the deep deltoid, and found that the mortise was maintained over about a year. So this adds new light to whether or not plain radiographs need to be supplemented with other studies, and that's certainly something that's ongoing. So next I'm going to talk, as Dr. Chapman asked earlier, about the gravity stress. I'm going to talk a little bit about how to stress the ankle, because this is important for us when we're evaluating patients in the emergency room. Classically, the external rotation stress has been the standard, and it hurts patients, and our hands get radiated, and patients tend to not like us for having to do this. So over time, the gravity stress was studied and was actually found to be just as reliable if the technologist is educated on how to position the leg, just as reliable in determining lateral displacement of the ankle. So next I'm going to go on to syndesmotic injuries. These are commonly found in association with ankle fractures. They've been found to be a diagnostic challenge preoperatively if the ankle mortise is congruent, and we know that the Weber C injuries with the higher fibular fractures most likely to be associated with a syndesmotic disruption as the forces travel from the medial side up through and out. The fibula is thought that the syndesmotic is frequently disrupted, but what we're going to find is maybe Weber C injuries are not the only ones we should be worried about these syndesmotic disruptions in. Bowden in 1989 did a study that has held a lot of weight in the literature over time. They looked at deltoid sectioning and a lateral malleolus fracture model, and found that the ankle still remained stable if the medial and lateral malleoli were intact, despite the syndesmosis being ruptured. They did that by creating injuries 1.5 centimeters at a time, moving proximally. This supported the idea that essentially we should be leaving these injuries alone if you have a medial and lateral malleolus fracture that are stabilized, and that ultimately, unless the fibula fracture is higher than about 3 to 4.5 centimeters above the mortise, there's no reason that the syndesmosis should be disrupted. But here's a clinical example. These are courtesy of Dr. Barei, that shows that even once you do get the medial and lateral sides fixed, there is still gapping at the syndesmosis, and this is leaving an incongruent joint, as seen here, before syndesmosis stabilization could potentially have long-term effects for the patient. So a study that looked at this, in particular at the Weber B fractures, because this is an injury that we commonly thought should not be associated with syndesmosis injuries, in fact showed that of 238 patients, 93 were still found to have syndesmotic instability, despite the fact that these Weber B injuries have been classically thought to really be unassociated with the syndesmosis injury. Another study described a technique for determining instability, and again, syndesmotic instability in 33% of supination external rotation injuries, as compared to 50% to 57% of pronation external rotation, which, to remind you, the pronation external rotation injuries are the classic Weber Bs that we all think should be associated with a syndesmosis. And with bimalleolar ankle fractures, to oppose the ideas of the Bowden paper, the syndesmotic stability could not be restored with simple lateral and medial fixation alone. As you can see, even with both sides fixed, they still could only get down to about 2 millimeters of opening. They recommended fixing the syndesmosis. An MRI study showed that there's a high rate of intraosseous membrane tears, even proximal to the fibular fracture, which is new thinking. When we all think of the forces exiting lateral through the fibula fracture, we typically have not thought in the past about the membrane tears going more proximally. So there are a lot of technical aspects to syndesmotic fixation that we're not going to cover today. There still remains a lot of controversy in all of these areas, whether or not we should be using larger or smaller screws, 1 screw or 2 screws, and whether or not those screws should traverse 3 or 4 cortices. The question of bioabsorbable screws and suture fixation are still out there and remain somewhat unclear answers for this problem as far as these screws eventually needing to be taken out. So again, the goal of fixing these is to prevent this latent instability, and in the 1980s, Leeds showed that without an adequate reduction and maintenance of a reduction, there really is a considerable risk of long-term degenerative changes. A couple of other studies simply showing that late instability really is a poor predictor of patient outcome. So these are injuries we do not want to miss. Likewise, more recently, Gardner's showed us that once we decide the syndesmosis should be stabilized with screw fixation, we're really not that good at fixing them, and that's not to be offensive to anybody in the room or watching this at home, but ultimately, even in a well-trained group of trauma surgeons, they had a 50% chance of malreduction when they followed these up with CT scans. And they found that radiographic predictors on intraoperative fluoroscopy were quite poor. So that's another ongoing issue in our field of how to make these right. I'm going to next talk about posterior malleolus fractures. These are commonly associated with fractures of the medial and lateral malleoli. An important anatomical consideration is that the posterior inferior tibiofibular ligament is attached to this posterior mal fragment as it displaces, and the posterior mal, as we'll find here shortly, does seem to play a pretty significant a role in the stability of the syndesmosis. The original indications for these is based on the size determined on the lateral radiograph, but as we'll see here, the lateral radiograph probably is not the best projection to diagnose the size of these. And then the next question is for further imaging workup to figure out the size of the posterior malfracture. So Haraguchi in JBJS 2006 described the different types of posterior malleolus fractures that we see most commonly. The number one most common type is this posterolateral oblique, which is, if you can imagine, although CT or radiograph does not show the PITFL, but you can imagine it connecting here, and the bony avulsion has happened with maintenance of the PITFL. The transverse type tends to be a little more complex, associated more with joint impaction, and likely involves some component of an axial load. And then there are these posterior lip types of fractures, which do have a certain association with posterior subluxation, but tend to involve minimal amounts of the articulation. So the indications are quite controversial still in posterior malfractures, and we'll go over those in the cases very shortly here. So long-term follow-up with less than 25%, and we're not really sure still how big a fragment is going to cause long-term DJG or even the syndesmotic stability. The posterior malcontribution with Gardner again in Core 2006 studying posterior malfractures, restoring the posterior mal alone was actually stiffer than providing syndesmotic stability with our classic syndesmotic screw fixation. And then a follow-up to that from the same group showed that when 31 patients were prospectively followed, posterior malfixation actually provided better fixation of the syndesmosis than the screws alone. So I'm going to move ahead here to some cases now. And I'm going to ask Dr. Barei and Dr. Dunbar to come up so we can go through these together. So this is our first case from earlier in the talk here. I think this gentleman presented with pain from a lateral malleolus fracture but an intact mortise. So first I'll ask Dr. Barei, what are your thoughts on these stress views, and how do you go ahead with decision making for a patient who presents with an intact joint before you get your stress test?
Thanks, Greg. I apologize for my voice and the sheen. But this was a very interesting case to me. This patient, to me, has a clear operative indication because I don't like the fibula. The fibula fracture is far too displaced, and yet the weight-bearing view would suggest to you that he has a stable ankle fracture. And so, to me, this generated a little bit of question for me as to understanding the real mechanics of how this fracture happened. And so to me, I had an operative indication, which was to fix the fibula fracture and stress the syndesmosis. But in my whole way of thinking of how did this injury happen and how could this injury have happened without a deltoid disruption, I wanted to simply understand it further. And so here we have a gravity stress view that I think corroborated the whole injury mechanism for me. So to me, that was just a surprising weight-bearing view. It also showed me that perhaps a weight-bearing view, even though you would think it would be an adequate stressor, certainly lied to us on that particular view, that it demonstrated a pseudo-stability that I think wasn't really present.
And if we then look at the intraoperative stress films, tell me a little bit about the indications for this intraoperative stress and why you chose it based on the level of the fracture.
Yeah, I think that the 4.5 centimeter rule, I think, is done. I think, to me, every ankle fracture that I take care of, virtually every ankle fracture I take care of, gets an intraoperative stress examination, because I think there's enough evidence to suggest that even low Weber B type ankle fractures or perisyndesmotic ankle disruptions of the fibula can have syndesmotic disruptions. And I think that we're learning that more and more of how patients do is related to like you said, stability of the ankle and stability of the syndesmosis. So I'm very aggressive at going after syndesmotic stability. And I also think that maybe we're stressing the syndesmosis incorrectly, and that for a given amount of force to the fibula, perhaps we should be checking them in an anterior-posterior direction rather than a lateral pull. And I think for a given amount of stress, you'll see that you have much more instability in an anterior-posterior direction. I think that's been borne out in some other papers that have been developed. So I'm very aggressive at going after anything that has to do with the syndesmosis, including posterior malleolar fractures.
Next case is another motorcyclist who fell onto his side at fairly low speed, healthy individual. And you can see a relatively significant displacement on the injury films. So what's the predicted injury pattern based on the initial radiographs? So there's a fair number of people in the room that are concerned about the syndesmosis, and I think that's appropriate. If we go ahead here, Dr. Dunbar, talk a little bit about that articulation, the distal tib fib, and how that helps you.
If you look at the responses folks gave, and the question actually said, what is the predicted? And if you only have what we have based on the literature, then I don't think that the answer, which said deltoid rupture without syndesmotic rupture, was not a bad answer, and which I think a third of the folks actually gave. But what we're learning is we have less and less firm ground to stand on. And if we're doing stress views early on, meaning preoperatively, to determine the instability, we're doing it more and more intraoperatively as well. So I think that with the amount of displacement we have, even in the setting of a Weber B fracture, you have to, number one, test that syndesmosis post-fixation of the fibula, but have a certain degree of level of suspicion when you have this amount of displacement. One more thing, the distal end of the proximal fragment is really not that displaced from the incisura. Nevertheless, if you see the displacement of the distal fragment, you really have to have some measure of suspicion that something else is going on.
If you stress the syndesmosis after you've put the hardware in, is that really the best way to go? Or do you have to put the hardware laterally into a place where you could then possibly put a syndesmosis screw in?
Excellent question. And actually some of our implants, even some of the newer pre-contoured ones, particularly the posterior lateral ones, make it sometimes difficult to place syndesmotic fixation. So as we're going on and encountering this exact problem, there are times when I might have gone to a posterior lateral plate, but I am putting a lateral implant in anticipation of placing a syndesmotic screw. So I'm finding that 5 years ago I was putting almost exclusively posterior lateral plating, or a high percentage, except for maybe pronation abduction injuries where you had lateral cortex comminution. When ones where I think I have syndesmotic, higher rate of suspicion, I may actually place that, because what we're finding is if you place the screw through a posterolateral plate, it's sometimes difficult to place that in such orientation that you don't get the malreduction of the syndesmosis that we're talking about.
In particular, I put up the contralateral side on this patient's postoperative films, and I was just going to ask Dr. Barei. I know this is one of his cases, and if you could tell us a little bit about your choice on looking at contralateral films intraoperatively, preoperatively or how your decision making happens there.
So I've gotten a great deal of respect for the syndesmosis because I think it's been borne out in my own experience and in the experience that you've already alluded to, how challenging it is to get a good reduction of the syndesmosis. And for me, I think it's challenging if I do a percutaneous reduction or a closed reduction or an indirect reduction of the fibula. I find that there's a lot of room for error, even with open reductions, of getting a good syndesmosis reduction. And so I think that we have all these numbers that you alluded to earlier on about tib-fib overlap and medial clear space and all this stuff. But I think what we're learning now more and more is that patients' anatomy varies. And so some people have completely intact syndesmoses and have values that would indicate that these are disrupted or that these are normal. And so I've found them less and less predictable, but I have found their contralateral side to be the most predictable. And one of the things that I think is useful is looking at the lateral radiograph and seeing how much posterior malleolus lies posterior to the posterior border of the fibula. Because as you've shown some nice examples of the problem with the syndesmosis is that people translate it either anteriorly or posteriorly. And that may be subtle on the AP, but it shouldn't be subtle on the lateral view. And so just an example of getting good contralateral films and using that amount of posterior malleolus to help predict whether you've got a good reduction of the syndesmosis has been useful for me.
Okay. Dr. Dunbar, any comments?
Yeah. I would say that this relates to the fixation of the posterior malleolus as well, as in so much as that's attached to the PITFL. If you've fixed that, okay, and your PITFL is intact, it makes sense that your syndesmosis is better reduced. Further, you've now got a posterior tether, so it'd be difficult to, you've got more stability, more to go on, and if you can, sometimes it even helps to go over the front to check the actual reduction under direct visualization, at which point you can get a provisional reduction and then move on to definitive fixation. Obviously, Dave used a posterolateral plate here, and actually, if you look on the lateral view, this is essentially where the fibula belongs, at least with a little bit of posterior mal overlap posteriorly. So I'm sure he did great.
I might add that it really does rely on a perfect lateral of the talus to be able to compare these films. So that's a really, it really takes time to get that perfect lateral in the operating room for comparison's sake.
Can you go back to the laterals? It looks like anteriorly the cartilage space is a little narrow compared to posteriorly. Is that just an anatomic feature of cartilage thickness? Or is there some shuck anterior, posterior in that joint that's always present in the lateral view? Just curious.
That's a good question, and I'm not sure. Do you want to take that, Dr. Dunbar?
I'm happy to say I don't know. It may be that he has some. I completely agree with you. It may be that when they have some of these higher energy injuries, there's also a capsular injury. So some of the time there is a bit of remaining shuck, if as you say, and it may be related to the loss of the secondary stabilizers like the capsule, or it may be pre-existing cartilage loss.
Chris, are you referring to the fact that he has an asymmetric joint on both sides?
Yeah.
So I'll speak for Dr. Benershka because he's not here, but some of this may be related to a gastric equinus contracture that's pre-existing. And what that may have been doing over time is chronically loading the anterior aspect of his tibiotalar articulation, as there's a tension band in the back and it's essentially spitting out the watermelon seed out the front. I think that may be what's going on.
How do you decide on how much compression to place on that syndesmotic complex? How tight to make those syndesmotic screws?
Thanks, Greg. So for me, I've gone away from clamps. I do open reductions of the syndesmosis. I use everything I can to get the syndesmosis reduced. I'll fix high fibulas, I'll fix posterior malleolus fractures, I'll do open reductions of the syndesmosis. I'll do all three. And then by the time I'm ready to do that, the syndesmosis should be reduced. I simply put my thumb on it, put a K-wire across it, and then put a positioning screw through it. I don't lag it, I don't clamp it, and that's what I do with it to make sure I don't overcompress it. It's a mobile joint. I don't think it needs to be more than that. Again, that's something we can talk about hardware removal, but that's what I think. Dr. Chapman.
Naive question, why do you fix a ligament with a screw? Why don't you repair the ligament? Why don't you put suture anchors through or something like that?
So I think the one reliable ligament you can fix is the posterior talofibular ligament, by virtue of the fact that it's rarely disrupted when they're in the setting of a posterior malleolus fracture. So, of course, fixing the posterior malleolus restores the incisura and, like Bob said, restores a tethering effect and reduces the fibula back to the syndesmosis. The anterior talofibular ligament, which is commonly ruptured, I've fixed in the past. I don't find that tissue in an explosive kind of injury to be terribly reliable to suture back together, and it would be the minority of people. I say, hey, there's the ends of the ligament, and I'll put a stitch in it. By that time, it's done. I've got a screw across it, and I've reduced it. So I don't find that trustworthy. The posterior one, by virtue of the posterior malleolus, I think is very good.
Yeah, I would have to echo that. Usually you don't find a lot of tissue there, and I guess as a trauma guy, I'm more comfortable than with screws than with suture anchors or what have you.
Dr. Dunbar, do you want to give us some thoughts on removing these screws, leaving them until they break?
Sure. I think that both are reasonable options. I would have to say that in our practice, we remove precious few, okay? But I do have friends from my community who have had this injury and did have them removed, and they definitely could tell a difference. I would have to say that, and that has that colored my practice? Perhaps if patients do have limited motion or are symptomatic, and I'm convinced that they have healed their syndesmosis, meaning they're easily 4 to 6 months out and haven't broken them, I would consider removing them. The younger patients with better bone typically will break these eventually because of the normal motion that Dave described. Older patients or those with poor bone stock will often windshield wiper as they regain that motion. If the screws break, we typically, and if they're symptomatic, we'd only remove the head portion if the shank is within the tibia. One rationale for removing, going for cortices, okay, would be that you could access the shank of the screw from the medial side if you so chose.
One more question regarding this topic for Dr. Barei. In light of the fact that even expert surgeons in the literature have shown the high malreduction rate, do you think the reason that people are, A, breaking their screws, and B, coming back with improving symptoms after they get the screw removed may be due to a held malreduction?
Yeah, I think that may be part of it. I think that once you release a malreduction and it hasn't had a synostosis, that you may be allowing that fibula to come back into the incisure a little bit more appropriately. And given the high rate of even with open reduction, of some degree of malreduction, I think that may be some of the benefits of it.
Let's do one more case, and this is a patient who presented with a low energy ankle fracture dislocation. See the injury films here. For the group, how would you go through the steps of deciding how to fix this injury? Okay, so mixed opinions in the crowd.
Could we briefly discuss if it's acceptable to actually obtain x-rays such as this one? Do you know what I'm getting at? Why was this x-ray obtained in a dislocated ankle? Why was this not reduced first before an x-ray was obtained?
That's a good question, and there are varying opinions on whether or not images should be obtained before or after, because you're just wasting time with skin likely at risk, at least anterior there, with the anterior distal tibia likely pressing on the anterior skin. Usually these are obtained because people are worried to start to pull on joints that look deformed without having some idea of what's there, but I think that's a good question. This person did get a closed reduction, obviously, and the next question is, based on the appearance of this posterior malleolus, would you fix it or would you not fix it? And it looks like most people would are happy with these images and would fix it, about half the room, but a large majority of you would consider a CT first. So let's take a look, and that's the appearance. So Dr. Barei, what are your thoughts on this as compared to the injury film, which looked relatively benign?
Yeah, I think that if I see an ankle fracture that has a posterior malleolus that radiographically I think is a posterior malleolus that I think I would fix, I would get a CT of that. And I think I get a CT of that because of the reasons you just showed. There are too many morphologies to the posterior malleolus that can have an impact on how you approach it and how you're going to manage it, that I want all the information I can get before I get into that and realize that if I do a posterolateral exposure, I may actually be on the wrong side or on a suboptimal side. So I think that I think for me a CT of the posterior malleolus is what I do if there's a posterior malleolus fracture there that I'm considering fixing. Dr. Chapman.
So I'll take the monopoly on naive questions here. Do I get you right? If we see a posterior malleolus fracture, are we supposed to get a CT nowadays? Is that what I'm hearing from you?
I'll say I don't CT every posterior malleolus fracture. For example, if I see a very small avulsion type of a fracture that I think is not one that I would even consider fixing radiographically, say, well, that's such a small injury pattern. There's a relatively stable injury. I won't CT that, but I have a low threshold for CTing anybody with a posterior malleolus fracture now. I won't say everyone, but I'll say I CT a lot of them now, and I'm being much more aggressive at fixing posterior malleolus.
Yeah, I would just say based on the images we had, just as we get traction views of proximal femur fractures and distal humerus fractures, this dislocated view is a jumbled set of bones, and it's really difficult to assess what we have. I think a reduced view would give us a better idea of what we actually have, and then maybe be easier to determine whether we need more advanced imaging.
How about some thoughts on the fixation construct chosen here, Dr. Barei? I believe you approach this from posteromedially.
Yeah, I mean, if you look at the CT scan and you look at the injury X-rays, you said, oh, that's a typical posterolateral avulsion type injury. Well, it's not that at all. You know, it's a posteromedial impaction injury, and so for me, fixation of this was a prone posteromedial exposure, I think, and a relatively complicated ankle fracture. That maybe on the original injury radiographs you said, oh yeah, it's a fracture dislocation, trimalleolar ankle fracture dislocation. But a lot of the work needed to be done in the posteromedial aspect, and I wouldn't have known that if I hadn't gotten a CT scan.
Probably time for one more case, another fracture dislocation. Also low energy. You can see the post-reduction films show a very small posterior malleolus fracture, but a well-aligned joint. So what's the next step in treatment on this one? Okay, and some people want a CT, some people want to fix the lateral malleolus and the syndesmosis. We'll go ahead here to fixation, which we went ahead with a fixation of the posterior malleolus. We talk a little bit about this is more of a peripheral rim almost type of injury, but it is transverse, goes all the way across the joint, and it has a tether there with the intact posterior inferior tib-fib ligament. Dr. Barei, do you want to comment on the fixation?
Yeah, I think some people would have blown off this posterior malleolus, and that's fine. For me, this is a fracture dislocation, so there's a huge amount of soft tissue disruption. It's a huge amount of soft tissue disruption that's not addressable. You're not going to be fixing the deep deltoid ligament. That posterior malleolus goes all the way across the joint, and it's not just got the posterior tib-fib ligament on it. It's got all the posterior capsule associated with it. And so for me, this injury pattern, I would like to much like the terrible triad of the elbow, I'd like to stabilize as many components of this as possible. And so for me, going after this posterior malleolus was really a way to help stabilize the whole situation. Even though it looks like a small fragment of bone, I think the injury pattern is illustrative of a really unstable fracture that I want to get as much stability to as possible, and that's why I went after that.
You know, I think this is one of the rationales for using a posterolateral plate this is a posterolateral dislocation, so that's where you probably want your implant. Additionally, once you've got that fixed or at least reduced and provisionally fixed, you can test posteriorly to see if the talus is following the posterior malleolus fracture. And if you've got a blown capsule, it very well may be. And you have to be thinking you may have to fix that. Even if you don't wind up doing it, you need to be aware of that. So having a posterior incision, meaning an incision no further anterior than the posterior border of the fibula, maybe even slightly further back, okay, so that you can get to the posterior malleolus if you have to, okay, working on both sides of the perineals, anterior to get to the fibula, and then posterior to get to the posterior malleolus, is really part of the thinking process when you're planning out what you're planning on doing.
So I think we're going to end there for the cases.